Cheah. I'm a consultant haematologist at Sir Charles Gairdner and Hollywood Private Hospitals in Perth in Western Australia. The question is, what is the management of patients with relapsed mantle cell lymphoma? This is an area which has changed dramatically in the last 5 years because of a number of new drugs which are active for patients with relapsed mantle cell lymphoma. Virtually all patients with mantle cell lymphoma will eventually have their lymphoma return. Even in young, fit patients who undergo high-dose chemotherapy followed by stem cell infusion, we know that even after 10 to 15 years, we are still starting to see those patients have their lymphoma return. The way that we treat people with relapsed mantle cell lymphoma is, again, dependent on their age and their fitness and the availability of clinical trials. So wherever possible, I enroll patients with relapsed mantle cell lymphoma onto clinical trials. I should say that first. In the absence of clinical trials, the drug which has been approved on the PBS in the last year or so is a tablet called ibrutinib, which is an inhibitor of an enzyme called Bruton's tyrosine kinase, or BTK for short. So ibrutinib and other BTK inhibitors are very active drugs in relapsed mantle cell lymphoma. Around 3 out of 4 patients given ibrutinib as a single agent. It's tablets taken once a day until they stop working. We know that most patients with relapsed mantle cell lymphoma will respond to ibrutinib, and probably on average for the ibrutinib will control their disease for a year or two, maybe even longer. The likelihood of remaining in remission on ibrutinib is you're more likely to have a longer remission with ibrutinib for less previous lines of treatment you have. So if you just had one chemotherapy program, you'll probably get 2 or 3 or even more years out of ibrutinib. If you've had lots and lots of prior chemotherapy, then probably you won't get quite as long. But that's certainly our main approach for patients with relapsed disease. So the question is what we do for patients with third-line mantle cell lymphoma. Again, at least in my practice, the answer is clinical trials, almost always. There are other chemotherapy drugs can be used, so if you haven't received a chemotherapy agent earlier in your treatment course, you can receive chemotherapy here. But really, by the time we get to third-line treatment for mantle cell lymphoma, it's highly desirable to access novel agents, and that's best done in the setting of a clinical trial. There is a drug called venetoclax, which it does appear to be active. Venetoclax is a tablet given once a day, which is an inhibitor of an enzyme called BCL2, which is important in a range of B-cell lymphomas, including mantle cell lymphoma. It's not currently an approved drug in Australia, but it does appear to have some activity in this setting, and there are various trials exploring it in combination ongoing. But I think the take-home message is participation in clinical trial is desirable wherever possible. So the question is whether the treatment of relapsed indolent mantle cell lymphoma is the same. I think the answer to that is yes. We don't know a whole lot about the behaviour of indolent mantle cell lymphoma after relapse, but it appears that by the time patients with indolent mantle cell lymphoma have progressed to the point where they need treatment, they've probably picked up additional mutations in their lymphoma which makes them behave like other kinds of mantle cell lymphoma. So the data around this are relatively scarce, but I mean I treat them the same way. Once they've had treatment and they have relapse disease, then I think that the way that we approach treatment is similar.